Hello lovelies, and welcome to today's video. My name is Alya and I'm so glad you stopped by. Today we're going to be talking about what to expect when you're having a cataract assessment before surgery. I'd love to introduce a lot of more what to expect videos on this channel, so let me know if there's a topic you would like me to talk about. But yeah, we're going to do another eye video this week, so stick around to hear a little bit about the patient experience, I suppose, with cataract surgery. So I thought we'll talk about cataract surgery today because it's a really interesting topic. I think that a lot of people do come through the clinic thinking they need surgery or not really quite understanding what is required of them. So I thought it'd be really good to get out there a little bit of background so that if you do have a cataract or you think you might have one, you're best prepared for your surgery. So first of all, I have to say, do a little bit of homework before you get into your clinic. So the first thing I'm going to definitely say is find an old pair of glasses if you have one, and make sure you use lubricating drops. Even if you don't have dry eyes, it's just a good idea to not have dry eyes on the day of your assessment. These are two things that can become really useful when the assessment is taking place. So I'm going to just start out by saying that one. Make sure you have any old pair of glasses or any kind of history with you, whether it's just an old script or an old pair of glasses, and then of course make sure that the surface of the eye is the healthiest it can possibly be, with just some over-the-counter lubricating drops is always a very good start. Now, cataracts are an interesting thing. Sometimes we have cataracts but we don't need surgery yet, and that comes from the good old concept of if it ain't broke, don't fix it. A lot of cataract surgeons are quite conservative in that respect, which is fantastic for you guys as the patients. You don't want to have someone who's a bit gung-ho and rushes in, but if there is a cataract there, it really does need to come out. Because what happens is that if you leave it in there for too long, first of all, it does diminish the vision, and second of all, it does make surgery more difficult or more technically challenging as it develops. So sometimes we've had to deal with some really complicated cataracts purely because of, like, for example, COVID. So people have been ready to have their cataracts out, then noticed a deterioration in their vision, but unfortunately because of COVID and because of all the restrictions, unless it was a desperate cataract where things were actually quite dangerous for the patient, they couldn't have it out. So a lot of cataract surgery has actually been delayed over the last 2 years because unless it was sight-threatening, you couldn't actually have surgery throughout all the lockdowns and all these things that have been going on. And that was, that wasn't just eye surgery, that applied to all surgery across the board in an attempt to stop the spread when the, more serious strains of the virus were out there. Thank goodness we're over that one, because that meant that a lot of people actually lost a significant amount of sight before they were able to have their surgery. The surgery itself was a little bit more challenging in that the denser a cataract is, the more kind of effort it takes to break it down and remove it. And sometimes that can mean that the recovery period is also a little bit more sort of lengthened, because the eye is just one giant receiver. So if the receiver hasn't been receiving a signal for a long time, it can just take the brain a minute, so a few weeks, let's say, instead of a few days, just to get the message. And that can happen regardless of the severity of cataract. Some patients do just take longer to recover, and that's fine, that's quite normal. But I do find that if the cataract is quite severe or quite delayed, it can actually take a lot longer. So that's just something to consider if you're making a choice whether to delay or to do your surgery sooner. If there is a problem, fix it. If there isn't a problem, then don't worry about it just yet. The reason that we need to assess a good eye, so a nice moist eye and not a dry eye, is because one of the main measurements we take is actually of the front of the eye. The curvature and the surface of the eye is one of the most important measurements we'll take as in the clinic. And the reason for that is because what we're effectively doing is measuring you up for a prosthetic of sorts. Your natural lens during cataract development hardens. It becomes opaque, it becomes what we call senile. It becomes no longer permeable to light. So that is why you end up losing a bit of your vision quality and sometimes sight. Now, the only way to correct a cataract is to remove it, and all we leave behind is one little membrane. Everything else has to get broken down using a very gentle kind of shaking method, a little bit of water just to break it down through a bit of vibration, and then it all gets taken out very gently, piece by piece, in the smallest and most careful kind of way. But once that little membrane is cleaned out, it needs to be you need something to replace it, because otherwise you won't see. And that little replacement is a lens. The lens looks a lot like the natural one, it's just a lot smaller, and it's acrylic. So to know what size lens, or what power lens, what curvature lens you require to give you your best vision outcome, we need to know everything we can possibly know about the dimensions of your eye. So that's where the surface is really important. The clinician will need to measure the curvature of the cornea, which is this front clear bit, the front here, curvatures all around, the size of the cornea, so the distance between sclera to sclera, or white to white. We'll need to know the depth of that first area, because we're going to need to predict where the lens is going to eventually sit itself. And we also need to know another really important thing, and that is the overall length of the eye. And if the machines that we use cannot tell where the start is, because there are air bubbles, or there are different kinds of patches of dryness, or any kind of distortions on the front of the eye, it's not going to accurately measure the whole distance. It's going to potentially muck it up a little bit. Now, generally speaking, cataract surgery isn't 100% perfect and accurate anyway, because sometimes the eye just doesn't heal the way the formulas predict. We do use several different formulas so that our predictions are the most accurate possible, but it is a little bit of guesswork. And guesswork in terms of educated guesses, experience comes into play, but you still do have that human factor. So the best chance you give your clinicians, the closer we bridge closed that human error factor and that healing factor. You want to get the formula as perfect as possible, because even they aren't 100%. So the more accurate your measurements, or the more accurate your eye quality is on the day, the more we can rely on the formulas then we use that data in. And the smaller we bridge the gap when it comes to little errors that can occur. Another thing that is really important to understand before you go in for your assessment is what you are looking to achieve from your cataract surgery. So some people, most people, will just want distance vision perfectly corrected. So you can drive a car without glasses, you can see the TV without glasses, that sort of thing. Which is, most people, that's what they want. If you're someone who's been short-sighted before though, it's a very drastic thing to suddenly not be short-sighted anymore, because short-sightedness, as much as it is an error in your vision, it's actually a really convenient one sometimes, in that you don't need glasses to read. And a lot of the time we do offer people monovision when it comes to a little bit of short-sightedness. I personally prefer a modified monovision, which is kind of like computer and distance reading. So one eye, your dominant eye, will always be your distance eye, and we try and get that as close to zero as we can, so that when you're driving the car, especially at night when it's quite challenging, you will see perfectly, even with the two eyes together. But because our brains are so clever, we actually have a little bit of a threshold that we can play around within. And within that threshold, we can achieve a little bit of monovision, where the two eyes will still work really, really well as a pair, but see slightly differently. So a lot of the time, I'll give people around about a 1.5 difference between their eyes, up to about 2. That will allow them to see computer, most things reading, and they'll only ever need glasses if they're trying to thread a needle or pick a splinter, or do something extremely fine. But of course, the most important thing, and this is something that your clinician must discuss with you, and if they don't, please do volunteer this information, is lifestyle. Because if you're someone who doesn't drive the car ever, who just doesn't have a license, do you really need your distance vision? Or are you someone who does a lot of craft work? Are you better off with having short sight? Are you someone who's never been short-sighted before and therefore shouldn't be made short-sighted, because that is a lot for the brain to learn? There's so many questions we ask during that assessment. So I guess what I would suggest is, in your homework, think about what it is that your eyes do. What is it that you mostly rely on your eyes to do? Are you on the phone a lot? Are you on the computer a lot? Do you mostly spend your time behind the wheel? Are you someone who still works? Do you need to be free of glasses, or is that just something that a friend of yours was able to do? Are you going to be comfortable having a pair of reading glasses afterwards? Are you prepared to take the risk of needing multifocals afterwards? These are all things that the clinician is going to have to discuss with you. The other thing is, be prepared to have a full health assessment of the eye. Sometimes we can't offer people anything of those kind of varieties, and we just have to go for best possible achieved vision, because there might be some pathology at the back of the eye just stirring in the background, going unaware, going undetected, but it's there. and we will find it. As part of the assessment of the eye is to make sure that the eye is healthy enough to withstand surgery and to achieve that predictable outcome. And a lot of the time we find that in fact there are some things in the back of the eye that can, lead things astray. And it's a really important finding because we need to take certain precautions during surgery, and also we need to prepare the patient. We need to make decisions that are the best outcome, not just for tomorrow and the week after surgery, but for 10 years down the track, 15 years down the track. Somebody might be working today, but they might be 5 years away from retirement. What are their plans for retirement? Are they someone who's an avid golf player? Are they someone who isn't interested in outdoor at all and wants to just sit and watch their telly, just catch up with the grandkids over Skype or over tea? These are things that are somewhat trivial, it may seem, but extremely important when we're thinking about what is it that we are achieving for people's sight. So you've got your history with you, you've discussed your expectations and your lifestyle and what you need your eyes for. You've had a full health assessment and been able to find out as much as possible about the back of your eye and the overall expectations there. You've had a really good chat to your clinician so that you both are on the same page about what the outcomes are going to be and even possible, what your recovery period should probably be like. You've made sure to use eye drops before the whole assessment so that the assessment is as accurate as possible. What is next? So the ophthalmologist will often have a look at the back of the eye also, because as much as all these machines are fantastic, it's not the same as looking at the whole picture in one go. A lot of these machines, they do kind of segment the eye. In fact, it's exactly what they do. They segment the eye into different sections that they're trying to measure, which is fair enough because you don't want a computer kind of doing more than it's being asked to. So it kind of makes sense. But what does that mean for the overall conclusion of your assessment? So the ophthalmologist, what they should be doing is looking at the quality of the scans and things like that, making sure that they're happy with what their assistant technician, orthoptist, or optometrist, whoever it is, has done. And a lot of the times the working relationship is such that they'll just say, hey, are you happy? And they'll answer yes or no, and that's sufficient enough, depending on how close their working relationship is. I personally love that the doctor I work for always has a look, and if she doesn't, I'll call her and be like, have a look, because, humans are human, and you never want to be in a situation where you've missed something. It's always better to get 4 eyes on something over 2. Right? The whole concept of 2 heads are better than 1. And if one of them's an ophthalmologist who's pretty clever, it's a good partner to have in your client assessment. As a patient, you want an ophthalmologist who's going to explain the procedure to you. Even if it's a bit icky and you don't really want to know the details, I think it's really important to at least have enough details to know what's going to happen on the day. Like, how long am I going to be there for? What kind of anesthetic am I going to have? Will I be groggy? Do I have to worry about any allergies? What special medications will you be giving me? Every ophthalmologist will differ. I like an ophthalmologist that likes to cover all bases, which means sometimes me having a little bit more aftercare, a few more drops to have, but honestly, it's a little bit of inconvenience for a lot of reassurance. So that's kind of what we tend to do at the clinic I work for. There's 3 doctors there and they all do use some sort of drops. They do vary slightly, but they all cover the bases so that you have the best chance of an excellent recovery and as quickly as possible. I guess my ideal patient will have some questions prepared as well. It would always be a worry for me that somebody's going into surgery without having all their answers, to all their questions, because it's just a little bit of a scary sort of scenario to be in when you're not familiar with the surgical procedure. I think it's always preferable to have a few extra questions asked and have them, have a patient that's confident and have a patient that's reassured, than have someone who's nervous going into surgery. I'm never someone who's worried or bothered if someone's got a few extra questions. I'd rather have the opportunity to reassure my patient and make sure that when they're going into surgery, they know exactly what to expect and exactly what's about to happen. Again, you don't want detail for detail. You don't want to know, what size blade or whatever that's going to be used. Generally speaking, it's a very clean surgery. There's very minimal bruising, and you don't really need to know all that much about what's going to happen. Like, I wouldn't necessarily be wanting to know every single surgical detail. I don't think that's that necessary. But what I would want to know from my clinician is what to expect. So I always tell my patients there are no stitches. It's a very clean surgery. There's minimal bruising, if any. There's minimal bleeding, if any. There's minimal pain, if any. Most people just have a little bit of irritation at most, and they're good by the next day when they start their drops. So, this little bit of reassurance can really, really, really impact the way a patient goes into the surgical procedure. And I think that's super important. Post any questions you guys have down the bottom. If you are someone or know someone who is looking at some cataract procedure in the near future, I'm very happy to answer the questions based on what we do at our clinic. So everyone's going to have a different set of protocols, they're going to have different machines and so forth. So that's just something to consider as well. So for more stuff, as always, do head over to Instagram. There's always more stuff going on there, and lots of cute photos of the dogs and the kids and all that sort of stuff. So definitely check it out. If you haven't subscribed, go ahead, click that button. It doesn't cost anything. Just help us out and let this channel grow. Wherever you are around the world, lovelies, I hope you're having a wonderful day, and I can't wait to see you on the next one. Bye.